Now, to introduce Dr. Walter Wodchis. He's a professor at the Institute of Health Policy, Management and Evaluation at the University of Toronto, and also the Trillium Health Partners Research Chair in Implementation and Evaluation Science, and a senior scientist at the Institute for Better Health. He's also a research scientist at the Toronto Rehabilitation Institute and an adjunct professor at the Institute for Clinical Evaluation Sciences. His work really embodies the scientific rigor, health policy impact, mentorship, and focuses on community-based integrated care that really kind of encapsulates Dr. Crichton's work. So it's an absolute pleasure to have him with us today. If you guys can help us welcome him onto stage.
Thanks very much, Lily. Real pleasure. Thank you. Wonderful. Thank you. Pleasure to be here. I have to say, in coming out here, I was a little intimidated. I've actually given talks in front of larger audiences, but rarely have they been of the caliber of the people in this room. And many of the people in this room know a lot more than I do about many things, and I don't quite know how I could impress you today. So I will endeavor over the next hour or so. It's the other thing. I'm not giving a little 15-minute snapshot here. This is a lecture. It's an hour. Sit back and enjoy. And I think we'll get going. I am supported by a research chair, Implementation and Evaluation Science, funded by the Trillium Health Partners Foundation, and I'd like to acknowledge them. They are really putting their money into community-oriented research, population health, and a learning health system. From what is originally a hospital foundation, that's quite unique. I also receive research funding from the Ontario Ministry of Health. What you'll see today is supported by them mostly, the Ontario Sports Support Unit, Ontario Health, the Canadian Institutes for Health Research, and also the Solicitor General's office right now. We're doing some work in mental health in public safety personnel. This is the Anne Crichton Lecture. And you had a little bit of an intro to Anne just there, Dr. Crichton's work here at UBC in the early 80s, and really a foundational time of health policy in Canada. It's when we really created the Canada Health Act. And what were the provinces doing to come together to enact that in their own provinces? And what were the repercussions? And there were budget cuts then. There were opportunities to advance work in the community then. There were health equity questions then. And Anne drove into all of these in her work. Particularly, Anne was an instructor here at UBC and created the Health Admin program, co-created the Health Admin program. Like, I teach in a health admin program. I teach finance, and I appreciate the opportunity to engage with people that become operators in the healthcare system. And such an honor to be able to do that. And Anne was such a groundbreaking person to create that program here in the 80s. So that is, to be able to give a lecture in her name is particularly poignant to me. She was also a very strong supporter of care in the community. I'm a very strong supporter, people know me, of integrated care, which is mostly happening in the community. And it's about shifting our care from acute focus to ongoing focus in the community. And that work extends back that far and further. She was also a policy analyst, and I'd say a policy entrepreneur in her work. And hopefully something I leave you with today will help you to be policy entrepreneurs in your work. One of the things about Dr. Sue's notion of introducing the Anne Crichton Lecture, and if you go back and listen to the inaugural lecture here from Dr. Fiona Clement, you'll hear this. It's also in the program around this lecture, is that one of the key takeaways from Dr. Crichton's team was that rational healthcare planning from an ivory tower is seldom successful. So I'm here joining you from the Institute for Health Policy Management Evaluation at the University of Toronto. I'm an old white male. I'm the first male to give this lecture, actually. But I will take with a little bit of humility that positionality. I am born in Canada, but of immigrant parents from the Ukraine and Ireland, fleeing their own problems in their countries. And I in my daily interactions, think about how can I support the health system to deliver care, particularly to those people with complex health and social care needs. And so hopefully I will give you some ideas about how we're doing that and some practical examples of how the Quintuple Aim can support that work over the next little while. And maybe along the way, I'll give you some useful tidbits to use outside of the ivory tower. Let me start with the value in healthcare and the Quintuple Aim being an international phenomenon. You're going to hear here, Jean-Fred is here from Australia. They are one of the leading countries in advancing this work. I'm going to talk about this work in Canada. People are converging on this idea. They may not always use Quintuple Aim wording, but if you look through the NHS in England, the National Health Service, what their focus is they're interested in staff workforce engagement. They're very interested in personal patient experience and health outcomes. In fact, you can actually go to every primary care practice in the NHS and get PREM and PROM results, which is pretty phenomenal. They're also very interested in cost management, surprisingly, and population health and health equity. They have particular initiatives around like 20 at 5. These are 5 conditions where they're most focused on the bottom 20th percentile of the population, how they can advance that work. So this work is not just here in Canada, and the ideas are not unique to us. But I'd like to start off, maybe get some groundwork here. Maybe better I'm going first now because the groundwork might have been laid for me already otherwise. I'm going to step back a tiny bit. Well, where did we start getting these paradigms? So one of the first paradigms and the longest enduring paradigms really started off Kissick, the iron triangle, and I was trained in the United States, and everything originates from cost, quality, and access. My earliest research was there is a trade-off amongst these things. If we want to improve quality, it's going to cost. If we want to improve access, it's going to cost. If we want to reduce costs, we're going to have to trim somewhere. I actually found in long-term care, which is where I started my research, that this was sometimes the case, but not always the case. Sometimes there was quality, and doing more care costs more money, but sometimes we actually could provide quality of care. So, for example, good pressure ulcer management in long-term care resulted in people being able to mobilize, saved costs in the long run. So it's not always a trade-off. Building on that work a little bit later, people started saying, well, that's just clinical. And Don Berwick at the IHI said, we need to get out of just this clinical space. And, Fiona Clement's talk really focused on this, is we need to think about health and not just illness care. And that really brought about the focus on population health. We had to give up access, now gets brought into patient experience along with health outcomes. And we have this new goal of population health and focusing that, and that really being a driver. Some people felt that wasn't satisfying. We needed another domain. Bodenheimer talked about the workforce. If you listen to Derek Feely, who was the IHI lead at the time, it's like, are you going to adopt this? Are you not going to adopt this? And he's like, well, people are talking about different things. They're talking about maybe workforce. We think maybe equity is actually what's most important. And then otherwise, just actually doing this work, organizational readiness might be an important point. But the Quadruple Aim took dominant step forward. And IHI then said, okay, we'll adopt that, but we're going to make sure people are thinking about equity. And hence the Quintuple Aim. And it took some evolution to get here. And this is now our focus. And I'll say, is our goal just getting more frameworks? Because one of the things Derek Feely really said is like, we could do quintuple, and I'll mention in a moment, maybe we could do sextuple aim. We really need to actually do something about these frameworks, though, instead of just thinking about it. And hopefully the second half of my talk today, we'll get into what are we actually doing about these. All of these frameworks have one principle at heart, and that is creating value in the health system. And we actually, the first year of this talk, value is the focus. How do we create value in the health system? And all of these are interested and focused on that particular, that's just the literature there. A colleague of mine, very esteemed colleague of mine, Dr. Robert Reed, who I've done a lot of work with, you'll see his name pop up a couple of times here in the slides, who wrote this piece on thinking about what is value, and that value is intrinsically tied to population health. And the ways that we need to get there are through thinking about Quintuple Aim goals of excellent patient experience, including access outcomes, that we have to have good provider experience because we're not going to get good patient experience if we don't have good provider experience. and that we do need to be cost-minded, not just on reducing costs, but ensuring that we get value for the money invested. And where are we getting that? So we have this thing. And I'm going to say that the Quintuple Aim is all about value. It is our expression of value. If we decide that the Quintuple Aim is our goal, it means that this is what we value. And again, I'm going to refer to Fiona Clement in the first lecture here, that she talked a lot about goals and the importance of engaging with the citizenry to understand what the values are of Canadians and what they expect of our health system. And that is what we should be focused on. And that, she actually did a little poll, maybe I could do that, on what people actually consider to be a value and what the goals of the health system should be in her work or in her talk. So I'm going to talk a little bit about value and what we think is important. And then I'm going to talk about empirically how do we actually get to doing this, because one of the reasons I got invited here is because we're actually trying to not just talk about it, but actually do something about it. And I'll give some examples. I want to highlight, though, the importance of this notion of equity in the health system, and that every time we think about the Quintuple Aim, you saw it as one of 5 aims. I'm going to think about it as central to the other 4 aims. That when we think about patient experience, we need to think about health equity. That when we think about provider experience, we need to think about health equity. When we think about population health, we especially need to think about health equity. And Rob did this picture, but it highlights, I think, a really good picture. If we think about the health across the population, the number of individuals healthy and unhealthy, I'm not sure it's exactly bell curved, but we'll go with this as an image of health. When we talk about advancing population health, we need to do 2 things. One thing we need to do is to shift the curve to the right. And the second thing we need to do is to bring the distribution closer together, both shift and squeeze. And no one gets left behind. If we want to advance population health, we cannot do it just by advancing people, like providing extra services to those people who are already healthy. We actually especially need to focus in on people who are on, for many circumstances, not just their own activity. Here's many circumstances that drives their health. So one thing is their own behavioral activity and their life. That's about it's their education. It's the environment, and it's the healthy environment, the neighborhoods in which they live. It's about their employment, their race, how they are treated every day, not just in the healthcare system, but every day in their work that affects their life. Healthcare itself, maybe about a quarter. And then biology and the environment being other aspects. But the healthcare system is not the only driving force here. And we need to be very conscious of the many other factors and the entire ecosphere in which we work. And we're going to move the healthcare system, but we also need to be doing it in parallel with other sectors, and even how the healthcare system impacts on these other sectors and other parts of people's health. And so I'll ask this question: is our healthcare system fit for purpose to achieve these goals? How many people think right now, for population health and health equity, our system is fit for purpose? Put up your hand. Okay, I'll just see if you're sleeping. How many people think that to advance population health and health equity, our system is not fit for purpose? Okay, people are awake. So we need to make changes. So the question is what changes, when, and how? And maybe we won't all agree, but I'm going to posit a couple of ways that we can make changes using the Quintuple Aim as a motivator to get us there. Currently, our health system is organized managing one complaint at a time, one disease at a time, often in one organ at a time. It's reactive sickness care. I don't think I get many disagreements in here. It's not, at the point of delivery, population-oriented, patient-centered, and at the point of delivery, not cost-conscious. Certainly, the assistant deputy minister and the deputy minister is very concerned about the cost management, but at the point of delivery, not really. And it's not an equity-enabling environment in most cases. There are many health agencies, and particularly community service agencies that are very equity-oriented. But for the most part, the healthcare system is not equity-oriented at the point of delivery. And so can an orientation around the Quintuple Aim help to address these problems? Central tenet for today's talk. So if the Quintuple Aim is the goal, I want to, still in my ivory tower, get a little, stay academic for a moment. Are these aims related? How can we think about these being related to each other? How does the healthcare system achieve the Quintuple Aim? Get into some of the ways that the operation that I would conceive the Quintuple Aim actually works together and the health system works to achieve. And that will help us understand whether this is important or useful framework. And then how would we measure? I'll get into that. And what would we do that data and information? That will be where I end off today. And I'm talking pretty fast. So I can tell because for where I'm at on the slides. So I'm going to reframe with some of the concepts I've already talked to you today, the Quintuple Aim of how I think it's actually produced. I am a health economist by training. I'm always thinking about what's the production model that's actually going on behind that's driving the outcomes. So you're going to have to think about industrial organization for a moment and how we produce health and how we produce the Quintuple Aim. So this is, I'll say, I talked about, what's driving health, and that's the patient community context. We have patient family activity and their individual health. They encounter the healthcare system. When they encounter the healthcare system, they encounter healthcare providers. Those healthcare providers are also working in a context. And that interaction is the care. That's the coalface of care in the healthcare system. And I'll say that if that's a positive interaction, we get better outcomes. And then if that's a negative interaction, therefore, in that context, provider experience is created by that, or is the environment in which that interaction happens. And that's essential. So understanding provider experience is giving us a signal of how well the interaction is happening. When that interaction happens, it creates individual patient experience. People have access to care, they have health outcome, and then they have their experiences. So these are driving the next steps. So patient experience is being driven by the encounters and by provider experience, along with the patient's own health and all of those community factors, not just in isolation from the healthcare system. We are now getting population health and health outcomes. So these are driving and they're scaled. And we generate cost primarily through the activity of the healthcare providers. So across the bottom, you'll recognize the Quadruple Aim. And I will say that the entire system works through the lens of health equity. Everywhere, in every interaction, it is always filtered through health equity. If we are not advancing people at all ends of the spectrum, we are not going to achieve these outcomes. And that's why I say we need to be thinking about it in each of the domains, not as a domain of its own, like did we do good equity? No. Are we doing equity in provider experience, patient experience, population health outcomes, and what are the impacts on cost? So what does it mean for value? So I would say value are the things that we are producing in the Quintuple Aim relative to provider experience, patient experience, and population health outcomes. I say that on the premise that those are things that we value. So if we come back, that these frameworks are intended to represent what we value and how we create value, that if we put those three on top of the amount of resources that we're spending, that's how we create value. So in that patient experience, you see health comes in patient-centeredness. People have been here and heard from speakers before and are well aware of a lot of talk that goes on relative to value in the healthcare system that gets very narrowly into the clinical pathways and clinical encounters. And in that particular view, we see the other forms like redefining healthcare in Porter Cheeseburg. It's that clinical encounter that they're thinking about value, but it's not system value. It's value in the clinical encounters. And if we want to have a broader mind about the health system, we need to think about these other aspects. There's probably some weighting among these. I'm ambivalent in today's talk about whether we value population health more than patient experience or provider experience, how we put them together. Are they multiplicative? Are they additive? But I'll just say for certain, those pieces are what we're producing. And the resources are what's going to produce those. But what happened to equity? Again, equity is the essential modifier of how we get this value. Okay, so we're not just dividing equally, we have to do it through the lens of health equity and understand how we're impacting those goals relative to costs across different elements of health equity. I'll talk a little bit about many aspects of health equity, but I'll talk a little bit after about some of the ways that we could actually empirically measure this. Because conceptually, health equity has many, many definitions, but let's think about what we can actually empirically do. So now I'm going to turn to this practical element and ask, is anybody actually measuring on the quintuple aim? Because we're actually going to do something about this. We need to make it practical. We need to make it feasible. We actually need to be doing it. So systems are talking about this. I went and looked for report cards on quintuple aim. I looked high and low. I tried all of my searching techniques. I tried all of the AI searching techniques. I couldn't find it. I honestly couldn't find it. And in fact, some webinar I gave last summer was like one of the top hits that kept coming up, and I'm like, ridiculous. CHI is trying. So I don't know if CHI has a sponsor here. I think they must have a representative in the hip and knee. They're trying, and they're doing some hospital-based prem. They're using their existing hospital-based patient-reported experience. I wouldn't say it's quite fit for purpose, but it's doing it. They do have patient-reported outcome measures, one of the few examples that they really put some work into this, and I want to commend them for that. They do have one of the better repositories of cost. It is aggregate average costs, not individual costs. And they are lacking, as I am also going to be lacking when I get to this part of my talk, on really good population health measures. It's clinical outcomes for now, but not to leave it off. I found another one too, and I have no biases. I declared my conflicts up front, but I did find on another place that purported to have a quintuple aim report. And I was so excited when I opened up. It's a quintuple aim impact assessment report put out by TEDoc. Their measure of population health was ED visits. So got a little ways to go. I did look high and low. Another review, and I saw Ibukun here, and she was one of the leads on this team doing this work, and she'll be up on the podium, I think, very soon. And they did this work for virtual care for Ontario Health. They're like, how would we assess the value of virtual care? And they looked all around the world. They did a very good review. And some of the frameworks, and they talked about population health, patient experience. These are the 5 quintuple aims to the right. The one on the left, which I'm starting to hear more about, sustainability. So if there's going to be a sextuple aim, and we get to say sex a lot more often, it's going to be sustainability. Nothing in these ones. And you can look across these rows. No one has it down. Australia has it better than most. But nobody has this all the way across. So what are we going to do? And from the policymaker's perspective, and I know many people here are from that, like, what am I to do? Experts around the world aren't doing. So hopefully I'll give you a little bit of some directionality to this, because it's very much not clear currently how to advance this and how it can help advancing things. So let me do a little bit on this, because I'll say it's not time to develop more frameworks or to analyze these frameworks. It's actually time to do something with these frameworks and empirically understand what value we're getting in our healthcare system. I'll say it's time to lean in. We have a lot of expertise in this room. People can help with this. Time to lean in, lean together, work together in this space. Because a goal without a plan is just a wish. And so let's get beyond just wishing and let's start thinking about what the plan would be to implement. I said before that I lead the Health System Performance Network in Ontario. We are funded by the Ontario Ministry of Health and Long-Term Care, and we are trying to push this agenda in Ontario. And I'm going to give you an example from what we're doing, how we're doing that. And what we do is measurement. And we are known, as with our support, for leveraging both research and evaluation expertise to guide policy and organizational improvement. We work very tightly with the ministry. Ministry funds us, and we do work that is of value to the ministry and to the health system to guide effort to improve health outcomes and patient experiences. Some of the examples is activating the Quintuple Aim performance evaluation. So we are now, in our evaluations, aiming, intending, and I will give you an example of how we're doing it. You be the judge of how successful we are, of having a Quintuple Aim performance evaluation. So every time we look at a program now, we look at it against the Quintuple Aim and say, how is this program achieving this? We do a lot of work on resource uses, health system challenges like high-cost patients, and developmental evaluation, health links being one in the past, integrated funding models. And I'm going to give you an example right now from Ontario health teams. How many people in this room are, I know I just sat with someone from PEI, people from BC, Ontario. How many people in this room are from Ontario? Okay, you all know what Ontario health teams are. How many people not from Ontario have heard of an Ontario health team? Okay, it's not bad. So we're just getting out. We've been at it for 6 years. I'm glad we're just getting out. So Ontario health teams are our approach in Ontario to advancing towards a more integrated delivery system. There are 58 Ontario health teams in Ontario right now, covering about 95% of the population. Still some rural, remote areas without coverage. The idea is to reorganize care from all of those silos at the top that each individual patient had to encounter separately, to having them more organized as a cohesive team. So the bottom being the idea that patients are receiving their care, including primary hospital services, mental health, community services, all from one team, an interprofessional, interorganizational network of healthcare providers. It is not making people into one organization, not putting people into one specific system. It is a network model where people come together in shared purpose to achieve some common goals. That would be the ideal state. Some places are getting a little faster than others. Current priorities for Ontario health teams are integrated care pathways, so working in specific areas of common interest, particularly around high burden illnesses, congestive heart failure, COPD, chronic obstructive pulmonary disease, and what they often call lower limb, because the issue that they were trying to address is lower limb amputations, but it's mostly about diabetes care, trying to get good care. Primary care networks are priority, primarily to attach patients to physicians or nurse practitioners. It's a fairly limited view, not yet. There's some work being trying to advance more broad views of primary care, but I'd say right now it's attachment to doctors. And the third area is home and community care, innovative integrated models. This latter space is what I'm going to talk to you about as an example right now. It's an area where we're actually doing some more rigorous evaluation that is intended to lead to policy reform and the modernization of home care across Ontario. So this is a space that aims to improve patient-centered home and community services integrated with other healthcare services. There is no one receiving home care that doesn't require care from other sectors of the healthcare system. No one receives just home care. And so this is actually a pretty opportune place to see how we're getting networks to work together in collaborative and shared purpose. Our broad evaluation is interested in understanding what changes are reliably implemented, most centrally, to understand the effects of these leading projects on client, provider, and system outcomes. You can see why this is a nice opening for Quintuple Aim evaluation, as well as assessing the conditions that are necessary for scale and spread of successful models. So going forward, what would we learn from these that we can use in other models? That's our purpose here. I'm going to focus very specifically on the second area, which is where most of our quantitative measurement is happening. This is very much a mixed methods, and I would say 2/3 of this evaluation is in the qualitative space. The front end about how they're organizing and actually implementing is all qualitative, and the back end of all, how are we going to use this to scale, is also qualitative. But I'm going to focus today on this middle space. Hardest thing to do here is to get signal out of noise. I'm going to not go into all of the methodological details in the audience today. If you have questions, I'm happy to answer what difference and differences means, what propensity matching means. But for now, I'm just going to give you a broad overview and introduce some actual data to prove to you that we can measure on the Quintuple Aim. The 7 projects that I'm going to give you examples on here cover 4 areas of home care interactions with the other healthcare system. 2 of them are neighborhood models, so taking a geographic space. One has 2 neighborhoods Another is starting from an apartment building and then moving into the neighborhood around that apartment building in a suburban area. 2 are embedded home care in primary healthcare teams. One in Frontenac Lennox, one in Guelph, at different scales. 2 are focused on palliative care, end of life. One through primarily a primary care network across a mostly rural area. Another being mostly urban hospital integration with primary care and palliative models and a community-based hospice programs. And then the last one is community crisis, which is what many people know about home care. You have people just in crisis when you get to long-term care, they get into the hospital, can't get them in a hospital. Like, how do we deal with that group? The scale is shown there on the left. This will be about 5,000 people at the end of this year. Not massive, but also not tiny, right? Across these programs. So what is our measurement plan? How are we going to do this in this space? So we have patient and caregiver experience surveys. We have provider experience surveys. We have health assessments and health administrative data. So drawing for a number of different sources. And how we thought about this in the programs, and we worked with these programs to develop logic models off the top so that they would understand what they were trying to achieve, what they were doing to achieve those goals, how we would know they were doing that, and what outcomes. So that logic. Their programs are first working with healthcare providers to reorganize how they work, starting with healthcare providers. So I'm going to start up in that logic model that I had earlier. I laid it out as a map, perhaps. Provider experience. That the start of this program is how providers change what they do. Then we'll get to how that's differentiated by patients. Then we'll get to look at the health system outcomes. So that is our ordering of how we look at this program. So the first thing we're going to look at is provider experience. And actually, I'll share with you some baseline. And in a few minutes, I can share with you preliminary, well, I wouldn't say preliminary, our first pass at follow-up results. So one of the questions we had on provider experience, I put this one up. We have a survey about 25 items, I think. But people talk about provider burnout. So that's why I chose this one today. So using your own definition of burnout, which statement best reflects your situation at work? This is a RAND question that was developed for AMA surveys, but we've now used it. It's been widely validated against other burnout measures. The blue at the top, it says, I enjoy my work. I have no symptoms of burnout. Then occasionally I'm under stress. Then I'm definitely burning out. The yellow is, say, the symptoms of burnout won't go away. And the red says, I feel completely burned out and often wonder if I can go on. So across the 7 programs, we see variation in this across all the providers. You'll see later there's about 250 respondents across the 7 programs. So this just shows you there's some variation across the programs at the originating places for those programs. We have questions about communication because the programs should help share information. So one of the other questions we have more around integrating is how often do you know about all the visits your patients have with other healthcare providers? And so this is just a measure that we have from the provider's perspective about, the flow of information and knowledge across the system from that perspective. I said we need to do equity in every domain. So I'm going to give you just samples along the way. So here's by race of the provider, Asian, whites, and others. There is some definite variation. Those being a very small group, so only 12 others. It's white-dominated population of healthcare providers in these models, and the white population in this has a slightly lower experiences of burnout, and then men being more rarefied in this population also have lower. But the idea being we have a couple of other dimensions that we're looking at, but it being important for us to understand this also by professional group. There's variation across professional groups, and how the changes are being impacted into these different groups is also essential, right? To understand how the program might be hitting that. So let's move on to patient and caregiver experience. We are now, it's like a little bit more involved, collecting that data, and we have some surveys in. I don't have enough data to bring you today. It's in the dozens across the programs as opposed to the hundreds like I just had for that, like 250. So I'm just going to tell you what we're collecting as opposed to putting the data results up today. So we had designed for home and community care about 5 years ago a new survey for clients and their caregivers, which is actually a provincial standard that's being used across the entire province right now. by Ontario Health. So we're leveraging that as our comparator, and we are directly surveying the clients in these programs. So we hit every client. It has to do with their involvement in home care. We did this co-designed with patients' family caregivers. So these are the questions that were important to them. So back to the engaging with citizens to set what's important. That's how we designed this. The provider tool that we have was done across providers, from physicians to social workers in the community, through many focus groups. We don't just make this up from the university. Communication to home care providers, explain things in a way that's easy to understand, and do problems because there's different people providing care. That kind of organization of care, does it cause issues and problems? Having different people is not a bad thing. What's a bad thing is if it causes problems. So here's like just an example of how we've done that in collaboration. So this is our tool. It's about 30 items. We have a brief one that goes out with about half as many items. I said we have palliative models. We're not using the tool on palliative patients. We're using a palliative care model that goes out to caregivers after the people have passed. And this is based on the Voices tool, which is our provincial standard tool as well. We didn't design this, we're just using it. But we're directly distributing it to caregivers. And then we have an administrative measure for caregiver distress. So based on something called the Resident Assessment Instrument, or RI-based tool. Some of you in home care might be familiar with. There's a measure of caregiver distress on that tool. And we see here what the level of caregiver distress is across the programs. And you can see it varies from 37 up to 73% of the caregivers in the programs feeling distress, that they can't go on with their caregiving needs. So something to be addressed. It also varies a little bit. It's higher in men than women, and it varies by socioeconomic status. Those at higher socioeconomic status, presumably because they can purchase more ancillary services. I'm making that up. Don't know if that's true. They have lower distress. Population health and health outcomes. We have good health outcome measurement. So proxying for population health. For those people who believe that qualities translate to population health, you'll believe that this is population health because we have a quality-based measure. It's a health-related quality of life measure. In this population, health-related quality of life goes down over time. It does not go up across all the programs. But we are trying to mitigate the amount by which it goes down. And maybe some programs can actually raise it, but these are frail, older populations, some of them very close to the end of life. We have to acknowledge that. So these are just some of the results across the different models at baseline, which is what I'm showing. I just had to put this up because there's policymakers in the room. Unplanned hospitalizations being one of the top markers of healthcare utilization. We also have low acuity emergency department visits for those who are keen on those measures. I don't actually think they're particularly meaningful in terms of the Quintuple Aim, but we're measuring them because they're meaningful to our constituents. And these are the rates across, and we'll continue to monitor. Presumably, if these programs do a good job, people will need less non-urgent emergency department care, and they will need less unplanned hospital care. So that's what we are marking as well. And we also have cost. We don't have individual microcosting, although we've been asked to try and do a better job of individual microcosting. But we have entire healthcare system costing for everything that is paid for by the public expender. We put this system in place maybe about 10 years ago to be able to do this work quite rigorously and reliable. So we can know how much money is spent for every one of these clients with pretty high reliability in a given year. So the dark blue is everything else. The light green is the amount of home care spending. So you see most of our home care spending and most of our system spending is on palliative patients or crisis. But this gives you a bit of a sense of, a third of the care in the neighborhood models is going for home care as compared to other healthcare system spending being primary care, pharmaceuticals, emergency departments, hospital specialists, labs, all those other things. So we do have a measure of cost. So we can actually look to see over time, pre and post, what we're going to get in value in patient experience, in provider experience, in health outcomes relative to the cost that we're spending. We're going to get that. I'm not sure how we're going to weight these, but we're going to be able to do this in some way or another. And we will be able to look at it at least across these spectrum of health equity dimensions: age, sex, and material resources. being a measure of socioeconomic status. Because these we can do reliably on the cost measure, which is based on health administrative data. When we do surveys, we can get way better equity data. But in the health administrative data, we're quite limited in what we can do. So hopefully you believe we can actually do this. Because we can. Little preview, we can actually do it on the evaluation front. These are the results a year in. So you see, I was actually more in the post, 150 in the pre, about 200 in the post. On the knowing about all the visits, that across all the programs has in general gone up. It has actually gone up across within each of the programs. So you can see that that has improved over time from baseline to, this is the, I think we did these around 9 months. We were aiming for 6, didn't quite get it out in time, but 9 months in. And also the context piece about healthcare providers in which they're working in these programs also improved in terms of that their workplace is taking time to think about ways they can improve. So that's a contextual piece as well. I do the design. I don't make up the results. Not a consultant that way. Sometimes things don't go like this, but we are seeing some of these positive results in these programs right now across all. We didn't do this on our own. Here's an example. We worked with the programs and we had evaluation organizing team meetings, and we did things like Menti polls about what are the important indicators to you, out of which we selected small subsets. Like, is there someone who's reliable in responding to questions and issues you have about your home care? Does the program think that's a good program goal? So we did this. We didn't make it up. With the programs themselves, we have lots of engagement. We have quarterly evaluation working groups. We have more frequently, like every bi-monthly meetings with each of the teams individually. It takes some time, but it provides more feedback and helps them do a better job of doing the things they do. And you can do this too. You have to have shared purpose. You need some data sharing. We're sending out individual surveys to providers, individual surveys to clients. We have to receive that information and distribute it. You have to have a few knowledgeable staff, particularly to workshop things with people. People who understand logic models can work with people. Most importantly, to translate the data into meaningful practice. Give people a bunch of slides of data results and go, hey, here's how you did. They're like, awesome. Or what? Mostly it's what? So what? How do I do? What do I do? That interpretation and taking the time to discuss and going back and feeding things back. We have 3 levels of accountability. Our first level of accountability is to the teams implementing these models and their planning groups. The second is to Ontario Health, which is running the program. And the third is to the ministry in making decisions. So we need to make a difference with the people who can actually action it first. That's a quality improvement activity. That's top of mind for us. Then we think about how this will influence. The questions I put at the beginning were policy questions. They're all policy questions. But the way we're actually going to work is at the front lines in quality improvement. How would we do this at scale? All we need is Quintuple Aim, right? Maybe we need a little bit more than just having a framework in mind. We need to have some brass tacks. We need to understand. We need to lean in. Some of the things, thinking about it, as I just said, as a quality improvement activity. So how are we supporting things? So we can collect data, but we really need to make it a quality improvement activity at the front lines. It has to be valuable to the people who are working on this. So defining outcomes. That shared definition and selection of indicators, and then telling the policymakers that that's what matters while measuring emergency department visits. Understanding what actions need to be accomplished with the teams and how are these actions related to the outcomes? Using evidence-informed practice and change plus innovations. Right? Innovations generally don't have a lot of evidence. That's why they're innovative. If we stuck entirely to evidence-based practice, we'd never get innovation. We need to balance. Embedding in co-design and implementation, and just building some data collection and rapid cycle feedback processes. It's actually not that hard if you decide that it's important. Anybody here has seen this before? I'm from the Institute for Better Health. That is my support. I cannot walk out of a meeting without putting this in front of people. I said we're embedding this in quality improvement. So what does that mean? This is what that means. We have a framework for understanding using a learning health system to use quality improvement strategies to achieve the Quintuple Aim. The one thing I'm going to say here is out to the right side of this diagram, you see the quintuple aim. The entire purpose of this learning health system is to drive the quintuple aim. And as you see it, it is the quadruple aim with equity in each of those quadrants. And so this is how we describe it. I'm going to spend just 3 minutes or 4 unpacking this a little bit. It's an engine. The engine drives equitable population health, patient experience, provider experience, and cost. The engine has 5 gears to it. It's population health analytics, understanding the problem. It's evidence reviews to understand if there's evidence or experience out there, having done this before. It's co-design of the work to actually implement change. It's thinking carefully about the implementation. How are we going to do this? And it's evaluation and rapid cycle feedback. Everything I talked about and how we actually work with the leading projects follows this idea and follows this framework of getting things to the front line quickly so that they can advance the quintuple aim. I just suggest you might have a look at this as a way of working. Certainly you need to think about how are you going to enact this. Start with shared purpose. Don't forget about that part. But these are some tools and tactics, and there's some papers that you can review. It doesn't just happen on its own. Organizationally at the top, you need leadership. You have to have scientific expertise, some funding, patient-family partners. You don't do co-design if you don't have partners. And building up the resource to have ongoing relationships with those groups and those individuals in equitably important groups, representative groups across your communities is essential. And that just empowers it. We did this project on learning health, on the leading projects without much of this infrastructure. But if you actually want to do this at scale sustainably, you need these. It also works inside a policy framework that has enabling health system capacity and priorities, laws and regulations and privacy, and governance and ethics and accountabilities. And I'll come back to some of those policy levers and how they play in just a second. It's how we work with the system, with the research leaning in, with the health system and communities to do this together, not in isolation. We have a lot of problems in the health system. I think your point beginning, like whose problems, what goals, very poignant. Care is fragmented, access is an issue, workforce. If you look down the little newspaper snippets on the side, emergency room crisis, lagging behind Europe in terms of access to care, people taking off hospital beds, which of these are we going to work on? You can decide that within your local constituencies, within your priorities. However, whatever topic you choose, no matter what topic you choose, think about how you're going to do it and think about, could you have a quintuple aim goal about this? Is impacting on emergency department visits and the volume going to have an impact on provider experience in the emergency department, but also in the community? Because if these people need care and they're not going to the hospital, they got to get it somewhere. And so how are you going to induce that, and how is that reaction? So don't forget about that side of things. And think about, no matter what your problem is, take a quality improvement approach and maybe think about adopting a learning health system approach. Doesn't matter the problem. Because if we keep doing the same thing and we don't actually radically change how we think about it, how we do it, and enact new processes, we're going to stay in the exact same rut, spinning a wheel like a gerbil. Or, as Charlie Brown often found it, back on your head. So some practice ideas, recommendations to round out here. If you are near the front lines or in an organizational leadership, engage with the community to build advocacy around doing this work. Engage with the communities to say what is important to you, and how would this system look different? Get that. It's the one thing I say is if we don't have patients in the room, we have lots of discussion and nothing happens. And it totally changes the conversation when we have the public, the patients in the room, to become more action-oriented. Patients actually don't have a lot of patience. They want things to happen. And drawing accountability to them. Providers also are much more polite when patients are in the room. Organizational leads take, this is actually why we have a healthcare system, is to provide care. And so we need to have that focus, and they have to be part of that conversation. There are learning networks that can help support this work. at a national scale, at a local scale. There's SPOR entities across the entire country that are supporting research and implementation. Most of them have a learning health system model. Ontario and Quebec both have this exact learning health system approach. And others in Saskatchewan and BC are looking at it and thinking about how do they implement learning health systems. There are community research networks and Kai-Hi for institutions. We've got partners. We have strong partners, smaller partners. Think about those partners in the work, depending on the scale you're working at. Using patient, caregiver, provider experience at measurement and scaling along locally relevant equity. Equity is not the same thing in Kamloops as it is in Prince George, as it is in Victoria or Vancouver. We have to be thinking about what are the equity concerns by local areas. So I won't say there's a single equity dimension that everybody needs to do. I'll say think about what's important in the community and just do something. Quality improvement to me is doing something. Policy recommendations. So let's start by why as a policymaker would we even think about this? So I'm not just going to tell you. I would ask you the question, how much are we spending on healthcare delivery? I just looked it up. $36 billion in BC. It's $91 billion in Ontario. What's it worth to know if health is being improved by a $36 billion investment? What's it worth? And what's the value then of the Quintuple Aim assessment if we think that that's what we think is valued? If we think about other sectors like education, would we monitor the value and impact of our education system by looking at attendance records? How many teachers showed up in the classroom? How many kids went through their classrooms? Or do we actually want to know what the educational outcomes are? We want to know what the educational outcomes are. We want to know graduation rates. We want to know grading. We have standardized testing. In our healthcare system, we're happy to mark attendance. Is that good enough? So to me, I say, just think 0.1% of expenditure, $1 out of every $1,000 would be 91 million in Ontario, 36 million in BC. What could you do with that money? You could probably get a reasonably good measurement system for $1 out of every 1,000. If you're actually doing work, the front lines, my line is, if you want to evaluate something with rigor, 5%. And I can give you lots of examples of where that's about the right amount. If you have very large scale, you can get away with less. But anything up to about $2-3 million, 5%. And then what are you going to do with the data? Leverage payment and regulation to require data collection and reporting, considering NHS models and US examples. I haven't seen the leverage points for Australia. Maybe we'll learn about these. But there's dollars. You're going to get dollars. You're going to report data. We'll provide the mechanisms by which we collect data. Don't put that on the providers. Provide the mechanisms and use regulation and use the data. Public reporting. Every government doesn't like public reporting. I don't know if they're policy representatives or political representatives. I know it will go online. But right now in Ontario, we're not doing a great job of public reporting. And we could do a lot more of that. And I think that that is what we owe our constituents and our citizens for having put $91 billion into the healthcare system. And attaching the public reporting to local quality improvement supports. It's got to be there. And it's better off. We can't think every primary care team is going to have a quality improvement expert. Not going to happen. We have to think about ways to support them through organized way. Practice facilitation learning communities. Advancing the measurement is based on values. If we don't value this, if people don't value this, it's going nowhere. But I suggest to you that people do value this. And if you go out and talk to people, we have I've run community sessions in the last year around proms and prems, and the extent to which the population thinks that there should be more accountability and reporting at the primary care level has been astounding to me, that they use that. And it has to be rooted in engagement. I'm not going to tell you guys exactly how to do things, except to say engage with the communities. I don't think anybody should be telling other people exactly how to do things. We should be co-designing all of this work throughout. and I'll end off there.
Okay, so first of all, we have a Q&A session that's open to the audience. So if you can go to slido.com and use the hashtag CHSPR, I think it should be 2026 updated. Let's see. And then submit your questions. And we'll start off with our discussants. So I wanted to introduce our discussants. So first, Dr. Mylene Britton is out of Sherbrooke. Sorry, everyone's very, very accomplished. So give me one sec. So she's a professor in the Department of Community Health Science and holds a Canada Research Chair in Clinical Governance on Primary Healthcare. So we'd love to hear her questions, and her research focuses on innovations to improve access and continuity of care, as well as centralizing wait lists. And we also have John Swoll, who is the Senior Policy Director at the Institute for Health Economics in Alberta, and he has extensive long career involved in bridging evidence to action-oriented policy. And so love to hear their thoughts on what's been said so far.
So good morning, everyone. I just want to take 30 seconds to start to thank Walter to be support the early career researcher in Canada. I have the pleasure to been mentored by Walter 10 years ago, and it was a huge lever for my career. So, Walter, you look around to have inspirational measurement country that using this framework. And I have a good news for you, because Quebec have launched last month. So probably it's why you didn't pick up, and it's in French. But the Commissaire à la Santé au Bien-être, so the Commissioner of Health and Well-being, just launched their Grand Repère, so major benchmark. Have you heard about that? It's really based on the Quintuple Aim and the value. The objective of the Commissaire à la Santé au Bien-être is really to do assessment of the performance measure of the health system, and they develop this, it's not a framework, but they report on this benchmark that they're looking different indicator based on all the value that you present. So I invite you to go to look on the website. It's in French, but hopefully you're going to have a high idea of what it's called. So Grand Repère is really based on providing a structure and approach to evaluate the value of health system. They did a lot of research. It's based on scientific literature. They did a forum with the population, as well as what is the data that are available. So it's quite amazing. You can, and they look what are their weakness, what are they stretch, and then it's all fuel about the improvement strategy. So Walter, when you say how we can measure, we have to start something. So they start something, and it's based really on benchmarking. And you have on population health, you can have on access and quality, and then where are we and how we can leverage that. And the equity part, for sure, it's really important, because we can compare where are we and where are you according to the other, and then we can make a plan to improve. So concretely, this approach, it's something that the government takes seriously, and they look, let's say Commonwealth survey, they have provider survey, and it's in close connection with the population. Well, they organize forum with citizens to have this, let's say, light to improve. So what I remember from your talk, it's we need measurement, we need to stop somewhere, we need data, and at some point, and also to high-level decision maker, we have to engage community. And I think that is a good journey that we start in Quebec. So hopefully you can be inspired. You can, Grand Repère, I think it's been launched last months. So definitely it's not in French, right? It's in French, not in English, but with AI, it's easy to translate automatically. So please do.
Hello, thanks. I'm John Sproul. Yeah, it is intimidating up here with all these people, but thanks very much for the opportunity. And Walter is I read Walter's stuff a lot, actually, because he's one of the few, particularly coming from the Institute of Health Economics. There's only a couple of health economists who actually work on system level analysis, as opposed to lots of people in pharmaceutical policy and lots of people in other areas. But he's quite insightful about choices that have to be made. Just a couple of comments as I was listening to it. I've been around a long time, but I really liked Triple Aim. I thought it was elegant, and this is just a personal comment, and Walter highlighted it. I hope we don't get to 10-tuple aim or 100-tuple aim as we go through. And I think that there are some of the measures which are enablers to the elegant 3 measures which balance each other off. And I observed in my time a bunch of health systems and ministers and political people got Triple Aim, and they were kind of embedding it in government plans around the world. And all of a sudden they switched it to quadruple and then quickly to quintuple. And I think that was a missed opportunity from the policy community wanting to reinvent frameworks rather than to refine them and make them more robust. And I do think there's a goal of the system shouldn't making the people who work in it happy. I get provider satisfaction, but I think that will make your outcomes better, will make the patient satisfaction better. And I think it just feeds a bit to what is a provider-centric system as a kind of a general goal of our goals and values. And that was a disappointment for me. Not that I don't believe that you really got to take care of providers and stuff, but in a system that focuses on itself, I think it's important to make that context. Particularly on the equity issue, a lot of the levers will lie outside the healthcare system, and this is just a personal thing of often I think the health system should be supportive to certain equity driving things, and you do better to give resources to local communities and have them run, and they can contract providers to help, because if you want something to be run in the most expensive way, probably get the health system to do it, just as a general observation, having worked with governments. The other thing is I believe in the accountability. I think that's really important, and the focus on measurement and what we could be held accountable for. I do think there's a lot of measurement that you could group into a Triple Aim framework that exists in provinces. So I was just maybe some follow-up question about where that's not possible. Maybe it's not been done consistently in a way, but I think there's a fair amount of data. The other one is new measures that are non-clinical, particularly I know you've done a lot of work in long-term care, which I think is an emerging major thing, and factors such as isolation and loneliness, other particular kind of groups which aren't going to be run by the health system. But clearly isolation and loneliness are key factors that are going to affect the improved wellness of being, and letting other people own that who have better skills in doing that, I think would be important. I think you've been very insightful in providing frameworks for decision makers. One thing that I would call on is I find policymakers either move too slow on things they should just do and get on with it, and move way too fast on things that are going to take transitional time. And from your work, I think, about looking at the Triple Aim evolutions around the world, some guidance on where to move fast and where to take your time, because politicians, I find, get it in reverse. And the deputy, I think service planning is actually the most important thing, and often feeding into the Triple Aim of forecasting and preparing for the future is, I think, an important aspect to moving forward, because that's often underdone. But that's me.
There we go. Would you like me to respond to those? And then I think the audience is going to be like, I'm set. I'm set. The audience is going to have questions too.
Yeah.
Want me to respond to these first?
Yeah, let's.
Okay. I see you're going to pull off some of these. Clock might be in the way. A couple of things. Mylène, on doit lire le français beaucoup mieux et beaucoup plus. We do in Canada, I do work in integrated care, as I alluded to earlier. And in our international case studies of integrated care, Quebec is always the example from Canada. The best models of integrated care have happened in Quebec. The reason most of us don't know about them is because they're written in French. That's a huge, within our country, incomprehensible barrier. Well, kind of comprehensible, but we just need to clearly get over it because it's not difficult. And I know like our program now, and I know you do it as well. Very simple. Webinars now should be bilingual, and people can read and listen and learn in whatever. All material, I think, in Canada really needs to be bilingual because we're losing opportunities on both sides and more dialogue. I will immediately learn about this. And Milan has done tremendous work directly on primary care as well. So thank you for that. My thinking today is that I am representing why the Quintuple Aim could be useful and how it can be used to achieve. Whether we need a specific aim around provider experience or not, or whether it is an organizational attribute that is necessary as a precondition to achieve the triple aim, we can have a discussion and academic debate. My first research in long-term care was in cost and quality trade-offs. My second was in how leadership and staff capacity and both staff ratings of their own workplace and patient ratings were the fundamental driver of quality and cost in long-term care, because care happens in the interaction between providers and patients. So it's fundamental, whether it's a specific objective aim. I don't think it's an outcome per se, but it's a necessary. And my view of equity is that it actually, and you'll see everywhere we present it, is it needs to be incorporated. It's not a separate aim. It's an embedded. So I don't quibble your approach. And I do think, and David Feely completely agreed with you when he was head of the IHI, that we need to actually do a really good job with the triple aim and then expand or think about that. And we'll get to another question, I think, pretty soon about the sextuple aim. But I think we need to do a really good job with the triple aim, but we do need to pay very close attention to providers' experience. And it's not totally in self-promotional plug, team promotional plug. Grace Sparrow's in the back of the room, I think somewhere, co-author on this paper on loneliness and experience, being tight related, paper coming out on March 23rd in the Annals of Family Medicine on this relationship within Canada about how people who are lonely have a much worse experience in their primary care practices. So direct link to these outcomes. So support for both of your comments. Thank you very much. You were not very critical. I hope there's more criticisms coming.
So looking at the ranking of the questions, Dr. Wodchis, you really made an impact on stating the importance of having specific measurements, and they kind of run the same theme. So starting off, do you have a recommended set of core measures that should be universally collected if you were able to snap your fingers and make it happen?
Yeah, so we've designed core sets of measures, like I said, with tools in collaboration with providers on the provider side. And like I said, from PT, like physiotherapists, occupational therapists, physicians, nurse practitioners, social workers in the community and clinical settings, 35-item tool. I think 5 or 7 of those would probably be enough for a core set. We should probably have a broad discussion and agree, whoever's going to be using these, on what that set would be, maybe some minor tweaks in wording. And for patients, I think very similarly, like we have tools that we've divided, but other people have done so as well. I don't think we hold, intellectual ownership over this. I will say, Jason mentioned Carrie Koleski on the panel for this meeting, not here today, has a framework. And I am going to tell you 4 things that I think are important to people, patients. And I don't think you'll find a survey, like a really high quality survey tool that doesn't fit into these. People need to easily access care. They need to feel heard. They need to know what to expect. And, oh my goodness. I said feel heard. Someone they can count on. Yeah. And I think if you got those 4 things, so there are some core metrics, and I think they're unprincipled. And that work actually was developed from international study of 275 interviews with patients, family caregivers in New Zealand, Quebec, and Ontario, which Milan was part of in the day. So not a small sample of interviews. So there are, I think, some cost, not difficult to figure out, all costs. And then depending on whether we go to other aims, there might be others. But I do think there's a core set of metrics, and we don't need a lot.
Just in regard to the metrics thing, which I think is important, and particularly accountability and who's accountable to it, because metrics are good for communicating to the public what you find to be important. But you've worked a lot across observing systems across the country and around the world kind of thing. I'm wondering about the organizational structures that you think have been emerging that are the most promising as to who would be accountable and rewarded or punished for not achieving certain improvement in metrics. What is the kind of, because it can't be everybody or the province, but those organized, because there's that balance of integration versus integration, local versus single health authorities for primary care teams. But are there some organizational structures that would be the target of being held accountable for particular measures of improvement?
Yeah. So I can't have a sweeping statement that's going to apply to all circumstances and situations. First off, I think if it's singular activity, then it can be singular accountability. If it's shared activity, it needs to be shared accountability. So just on a principle, and then it is on everybody's accountability list. And people can't shrug, like they are actually accountable for shared purpose. And what are they doing to contribute to that shared purpose and that shared activity? If it is in the example of leading projects, the home care integration, we have home care service delivery organizations. We have home care as an agency doing care coordination, and we have primary care practices and physicians and interprofessional teams working together that are shared, and they have to all individually and jointly have accountability for the measures of patient experience in that environment. And if they're not doing well and they're not improving, they are each going to have rewards and penalties.
Oh.
Yeah. So there's no free riders.
Yeah, it's the rewards and penalties, whether those are actually enacted or whether doing nothing and staying the same is something which is easy to do.
I will say the UK has had a bad experience with having too much emphasis on sticks, carrots. So we need to be a little bit careful about that. But I do think that transparency and accountability and that individual transparent reporting, actually people are quite responsive to. People don't like to look like their people have bad experiences. Yeah.
Yeah, that makes a lot of sense. And I think especially when we get to be more comprehensive of what we define as health, like you said, there's so many things that are impacted by like people's entire states outside of their care experience, like loneliness. And so it's hard to integrate that with appropriate accountability. Still on the topic of measurement, so what do you think are some of the reluctance to investment at like a policy making level? And is that different geographically in the country?
I think that I'll speak mostly from Ontario, it's my greatest experience, right? And I think that in Ontario right now, it is difficult to have policy move without political support, like the elected officials, and that the elected officials feel that if they are putting services in place, that is the end of their job, and that it is not actually seeing that they get any outcome being part of their responsibility. Their responsibility is to put services in place, and that's where it ends. And I think, honestly, it is up to the public to react to that situation, and that public can be organized and supported through community and patient associations. Researchers can play a role in helping to provide evidence. I mean, there's a line between advocacy and advice that is always a bit of a thin line for a researcher to have credibility. But I do think providing evidence and data for those organizations, maybe not flying the flag, but I personally feel what we need to do is a lot more about getting things to people, patient groups, and citizens and representatives to hold their officials accountable because I think that is actually the thing. I mean, scientists need to keep doing the work, and we need to keep having forums, and we need to keep speaking to politicians and bureaucrats. We're not absolving of that. In fact, I think this is a very strong role, but I think the reluctance or the question here at hand is that they feel that when it comes to the populace, their politicians are really not accountable to me other than a member of the public. But they are accountable to their constituencies. And I think that's actually where the action happens. And frankly, news reports and things, the hospital report back in the 90s was started in Ontario by a news report by Lisa Priest saying that hospital quality was not so good. And that made it a public concern, which led to public reporting.
And maybe to complement, we need data at all level of the health system, at the system level to have this micro direction, but as well at the organization and at the local level. And as we said, we have different needs according to the population. So we need to better understand the need of the population at the local level based on the data, and not only on the health data, but what are the other determinants of health. And we need to have this in the integration of population health to respond and address those needs. And again, we have to align the incentives, how we working together and based on this metric. And probably you hear about the huge fight this last fall in Quebec against the government and the family physician, but it was a nightmare, and it was a bad experience of how to use metric to improve the system. It was specifically on remuneration, metric that a lot of physicians didn't have power and action to those metrics, but they were, the direction was there. It was specific on physician when we know that it's team-based work. So I think we have to align the metric to what we want to achieve and be careful to not use as a coercive way. We need accountability, but they have to be aligned where our action could be.
I think there's a law, isn't it? I remember it's an eponym, like once you start measuring something, people like it no longer becomes a good metric because people find ways of manipulating it. I think the next top voted question is really in line with what we've been talking about. So it seems like altering the measurements is a issue of governance and leadership. How much do you think the data impacts leadership? Or
I actually think we could go light on this question because I think it's highly related to the prior. And I think that the role, I mean, there are still roles of things like media and stuff to put things out there, and they can often like put data on the front pages of the newspaper and make it publicly available in places even when the systems are not. And I think that will just drive, again, it's just another mechanism for the people to have a voice.
yeah, it's more about, instead of kind of what the news media finds like interesting to people, we should do a better job of making the relevant information at the front lines of the public. And that's the biggest leverage that we have.
And I'll just add to that, perhaps better to have 1, 2, or 3 messages than 5.
Yes.
All right. I think, let's see what else. Do you think, John, do you want to?
Just, I thought you might have a gap there. So it was going to help out. But just in terms of the performance reporting, which Walter brought up, which I think is important of transparency, as you noted, as a real significant driver for behavioral change. And across Canada, there is a lot of political oversight at the provincial level about what reports often get released, in which they come through agencies. And so I think a real public policy thrust would be to ensure transparency and regular reports that aren't guided by political decision making. I know in the UK and some other places, they have some major survey reports in primary care that are drop dead on a particular date, and there's no government control over it. And so I think some of those quality reports of increased transparency would be a major kind of policy change, because right now it's subject to decision makers, often from the health service or the government. And if the information isn't very positive, they are reluctant to sometimes release it. And so you get delays. So.
The second one, the third one, either.
Yeah, so we can have something a bit different. So I think, yeah, I'd be really interested here. We all talked about there's a lot of drivers of population health that sits outside of a healthcare system. And it seems like we made a really conscious aim of incorporating those when we shifted from like triple aim to quintuple aim. Like, what do you think the impacts of that are, and how can we better incorporate like that change in what we measure?
Yeah, so I think here is where health equity comes front and center. And as I talked about the population health and not being able to actually advance on population health without advancing on equity. And if we look at inequities, we have great opportunities to dive in and understand, and then also to step back. So I'll give you a concrete example. In other aspects of evaluation of Ontario health teams, for example, we look at things like unplanned hospitalizations or access to cancer screening, which is very much a population health kind of concern. And then we look at it across material deprivation to know that those people who live in neighborhoods that have lower socioeconomic status have much lower screening rates than those in areas. And that's actually used by the teams to then decide and go out and do community engagement. The data don't tell you exactly what to do. They just tell you where the issues lie. And the fact that people had jobs that didn't allow them to get to the clinics between 9 and 5 on Monday to Thursday, led to mobile clinics, going out, doing outreach, sitting in malls and setting up, kiosks and pop-ups in malls, where people would be, where people, the lowest screening rates are the people who actually do not have regular primary care providers in Ontario. Like we go up the scale, people in family health teams or organized models have the best screening rates, fee for service a little bit less. Down to people who don't have a physician having the lowest screening rates. Well, sending out messages through your primary care providers, sending out a message to say, call your primary care provider doesn't help those people. So we need a different strategy. And that's where I think using data and using equity stratifications allows us to unpack what the problem is. So it's a real being able to shine the light.
Awesome. Yeah, thank you so much for our whole panel for starting off the conference with a bang. And thank you again, Walter, for sharing all of your knowledge with us.